Welcome to the Dose of Optimism, where I talk to the optimists in healthcare. My name is Omkar Kulkarni, and I work at one of the world's best children's hospitals, where I lead innovation. I started KidsX, which is a premier international startup accelerator for pediatric innovation. And over the years, I've met thousands of startups, investors, and innovators. Every one of them has a story, and every one of them is optimistic about the problems they're solving. On this podcast, you'll meet amazing people who will share their stories and what makes them optimistic about the future of healthcare. A little note before you get into this episode. This podcast is for informational purposes only. We are not offering medical advice, and we're not endorsing any products. Please talk to your own physician about your health or the health of your children. All right, let's get started. Dr. Rosen, how's Alaska?
This time of year, it's worth being here. But for most of the time, it's a struggle.
Are you there year round or?
Yeah, I've been here for 32 years now.
Wow, you're at Anchorage?
You know, I married an Alaskan lady. We got a big family, and
Nice.
I got my practice. I'm the only oculoplastic guy in Alaska.
I'm sure. Nice to have you on the show.
I was thinking we could talk about what's going on in Alaska, why we decided to build a teleophthalmology platform and why I think it's changing the model of eye care.
Alaska is like a really unique perspective around kind of remoteness and being distant from specialists.
It's the largest multi-specialty practice in Anchorage, which serves really the entire state. And you can't help but serve the entire state. I'm the only oculoplastic guy, neuro guy, since the Big Bang. I mean, there's never been anyone to do this with these subspecialties. And unfortunately, there may never be someone after I'm done. I've been here for 32 years, and it's like throwing a fastball. You can only throw a 90-mile-an-hour fastball for so long. After a while, you just can't do it. Taking call for 30 years can be rough.
Yeah, I can imagine. So in terms of Alaska and specialty care, Anchorage is really it. And in terms of ophthalmology,
There's really not that many ophthalmologists in Alaska, and there's less that are working full time. We have a bunch of folks that are working part time, like me right now. A decade ago, I was full time and it was pedal to the metal. But now we have about 10 that are here and 6 that you can count on to take call. Not everybody takes call, so really only have one private hospital that has EMTALA emergency call. We have 2 pediatric ophthalmologists. They're not really full time either. So there's a real problem with getting folks to come up here. It's a challenging place to live. And unless you grew up here or unless you married someone from here, we're skeptical of folks who come up because they come up, they visit, we provide everything. And then, as soon as they get back home, they say, well, hey, thanks, but no thanks.
So tell me about what you built here with Open Eyes and why you built it. And
so in Alaska, we have about 24 hospitals. This started about a decade ago. And what I did was I networked every hospital in the state using something called Call Doctor, which is an EMTALA-based, leverages EMTALA way to publish and broadcast every specialty that's on call, trauma call or night call. So if you're having an MI in Nome or Barrow or Fairbanks, there's no cardiologist there. But wouldn't it be nice to know in Anchorage who's on call rather than waiting 4 or 5, 6 hours, trying to get someone to pick up the phone from the emergency room? So what we did is we built this program that did exactly that. It connected all the hospitals, linked them all up, and published the on-call schedule. Usually those are siloed because hospitals are afraid to broadcast them because of surgical competition from neurosurgery, ortho, et cetera. We broke it down and it worked. It reduced the time that a physician in an ER got a clinical question answered. It also reduced the time that, say, a cardiologist or an ophthalmologist who had a ruptured globe or an orbital fracture or a retinal detachment knew about the case. Things just got connected, linked, managed much more efficiently and effectively. And I sold that about 5 years ago now. And after not being able to recruit anyone to come to Alaska, particularly to take my place, or even glaucoma for that matter, I said, we need a program or a model that can assist non-ophthalmologists with ophthalmology-related clinical questions, clinical issues. And that can be in senior facilities, it can be in remote areas, it can be in Department of Corrections. It's where folks are trapped or can't mobilize for whatever reason. And what I did was I built this program that uses AI to assist in the diagnostic support, as well as generating reports, extracting data from referrals, and slotting it into appropriate appointment slots with the appropriate specialist, and just making the whole process more efficient, reducing the drudgery that the office has to go through, and making it so a patient doesn't have to wait. A patient can wait 4 or 5 months to see a guy like me or one of my partners, and we want to reduce that time.
So walk me through how it works. So let's say you're a gnome and you've got your kid and they've got some sort of an issue with their eyes. What do they do?
Right. So let's say a kid is playing baseball up in Nome or Sitka or Barrow or Bethel, and he gets hit with a baseball. He has a high FEMA. So what'll happen is that the ER will have a tablet or have the program. There's two ways to collect data. You can either do it on a tablet, and that's more for the Department of Corrections or the senior facility where the equipment doesn't exist, and you still need equipment in ophthalmology. Ophthalmology is image heavy, it's data heavy, and you need special equipment in order to capture that data. So the data is captured either on this tablet or an iPhone potentially. Once that data, visual acuity, intraocular pressure, a fundus photo with a handheld fundus camera, something called an eye care that measures intraocular pressure, even an external image can give you a lot of information with an iPhone. We even have this thing called OLEYES, which captures visual field exams and visual acuities. That gets uploaded from the tablet onto a desktop screen. And then the ophthalmologist is alerted, and he's alerted through an SMS message or an email, or it's been scheduled. So you have multiple channels. And then he opens up the exam and is able to use video conferencing technology to see the patient, offer an interpretation of the images, offer diagnostic interpretation, as well as an urgency score. Is this routine? Is this urgent, semi-urgent, or is this emergent now? Get on a Medivac and come on in because you have a ruptured globe or you have an RD we have to take care of. And then it's all documented. The doctor goes first, and then the AI follows because it's here to help the doctor, not to remove the doctor.
And then based on that, it prioritizes and perhaps triages the urgency of the treatment plan.
Right. So you could think of it as a really sophisticated triage mechanism or application, and it's really very good. I've seen over 300 patients with it now.
Wow.
People really want it and need it, particularly in the Department of Corrections.
So what's next? What are you looking to use this for as you expand from 300 to 3,000?
Right. So we actually have a contract, believe it or not, with a senior facility. We're lighting the fuse. We're launching. Our dev team is working on polishing. I built the MVP, the proof of concept, and validated it, tweaked it. It's really a pretty neat program. It does a lot. It takes an ophthalmology exam from a guy who's had 30 years of practice, understands the patient journey, and then coded that experience onto a screen. And it's really quite extraordinary. I think it's going to change the model of the way eye care is delivered. I think it's going to improve access. I think it's going to reduce costs. It's going to reduce tests that aren't needed or medications that are given that aren't needed because you're going to get an expert to offer the diagnosis, urgency score, interpretation of images, and the treatment plan and next steps.
Yeah. Dr. Rosen, thank you for joining me on the podcast and talking about your great work. I'm excited to see you go from 300 patients to, 3,000 patients over the next, hopefully short period of time.
Yeah, yeah. Great to be here. Thanks for having me.
I'm Ivan Terekov. I'm the Director of Research Informatics, AI, and Technology at the CHEO Research Institute in Ottawa, Canada, and I'm the technical lead for the ThinkRare project.
Alex White Brown. I'm a clinical genetic counselor by training, and I'm the project manager of the ThinkWare project here at CHEO in Ottawa.
Let's start with CHEO. So tell me more about the organization, the community you serve.
CHEO is a pediatric hospital in Ottawa, Canada, so our nation's capital, and we serve majority of the catchment areas of Eastern Ontario and Western Quebec, but we also serve some northern communities, our First Nations communities up north, and so we'll have some fly-in and fly-out patients. but we are the largest pediatric center in the region, and primarily most of the complex pediatric patients will come to us.
Okay. So tell me how that background orients to the story of the product you built.
Sure. Actually, I mean, I think that was the perfect spot for us to be in because we are regionally important, but we're not a terribly large center. Within the hospital itself, we have great connections between our clinicians, our researchers, our data people, and ethics folks and privacy folks. So it's kind of easier to get projects going. But from the regional perspective, that's, all of the complex kids really do come to us. And so we have a lot of the data silos that you would typically have within, let's say, a large urban center like Toronto. We really kind of have all of that data with us. We've also had our EMR for a very long time. We're actually the first Epic customer in Canada. We started with ADT and scheduling back in 1994. We didn't actually implement the clinical parts of Epic until 2013. We started with the, rolled out phases of the outpatient modules, and then culminating in 2017 where we did the inpatient and emergency department modules. We've had a lot of data to work with, and we're always following kind of a one patient, one record model. So we had a pretty complete view of the patients. And so actually myself on the research side, I was tasked with creating the data warehouse program where we are taking all of our routinely collected health data and making it available for our researchers to do research projects. And so how we got linked up with the genetics folks and Alex and team was I was doing a bit of a roadshow of, the capabilities and the kind of data that we have available to work with. And I just was happening to present to the genetics department, and we have all this data, but we need ideas from clinicians, and we need to be solving clinical problems, but tell us what we can tackle. And so Dr. Boycott, Alex and team were sort of saying, you know what, well, based on the prevalence of rare disease, and we have a very large rare disease research group here in CHEO. We're missing kids. We feel like based on the napkin math or catchment area, we probably should be seeing about 100 kids more a year than we are. And so, can we find these kids? Is this a problem that we can solve with data? And so we rolled up our sleeves and got to work on this project. And then the pandemic hit, so it was actually a very interesting time. We had to pivot very hard. We all went remote, and over the course of a few years, we've moved this project all the way from the research phase into a full clinical implementation, and now we're scaling it to other centers in Canada.
That's great. So tell me about what it actually is. How does it work and what's the problem it's solving?
The main problem it's trying to solve is really the diagnostic odyssey. And that's when the symptoms of a disease begin to the time at which that patient receives their diagnosis. And we know based on data and the literature that rare disease patients endure much longer diagnostic odysseys than other patients, typically lasting anywhere from 5 years, 10 years, and sometimes more than decades, more than 20 years. So back in 2019, right before Ivan and his team were doing their roadshow saying, let's use all this data, the Global Commission to End the Diagnostic Odyssey for Children with Rare Disease came out with these hypotheses for why the diagnostic odyssey for children with rare disease was so long. And one of them was that they hypothesized that if you're not a genetic specialist, you might not have the specialized training to identify and recognize these patients and ensure that they get referred to genetics for appropriate genetic testing. So the Global Commission at that time made this recommendation to better equip these frontline providers with tools to identify these patients so that they can get referred for appropriate testing. So that was really the problem that we were trying to solve is can we take these diagnostic odysseys that are 5, 10, 15 years and can we shorten them? Can we make it smaller by identifying these patients on a day-to-day basis, make sure they're getting referred when before they weren't? And we've shown great success through this, both retrospectively, where we were identifying patients in their late teens who have been bouncing around the system for more than 17 years. And then prospectively, as we started running this on a day-to-day basis, identifying patients as young as 2 months old and getting them their diagnosis by 5 months old. And we know that a clear diagnosis is the cornerstone to informed care. So this allows families to have answers, an explanation for their child's health issues. It allows for reproductive decision making, cascade testing for other family members, entry into clinical trials or treatments that might be available. But one of the quotes we hear very often from families is, it really just allows us not to blame ourselves anymore. It gives us clarity on why our child might be struggling in school or having, these issues with their heart. And for us, the rare disease community and the rare disease patients, providing these answers for the families has always been top of mind when putting this together.
So, what is the product itself? What does it look like for the patients and families? How does it work within your technological and ecosystem?
So essentially, we're looking at all of our active patient population. So the last 3 years of patients that are being actively seen at CHEO. And every day we run the algorithm on our patient population, and patients are identified based on the algorithm criteria. And then at the end of the week, Alex reviews the charts. So we tune the algorithm such that we're not flagging so many patients that we're overwhelming the downstream genetics referral queues. We're really tuned it so that we are looking at the most probable rare disease patients, but also at a volume where it's reasonable. So we're actually flagging about 5 to 10 patients a month using this method. So they very cleanly slot into our usual referral pathways. But the diagnostic yield is 70% on the patients that have gone through the entire process. So a patient typically referred to genetics, getting the testing like a whole genome or exome, they might get a diagnosis only 35% of the time, but we are doubling that. So we're definitely finding the right patients. And so once Alex reviews the charts and confirms eligibility, then we are notifying the most responsible provider to request that the patient gets referred to genetics, and that they obviously talk to the family and ensure that the patient is interested in getting that testing done.
So before you did this was a very manual process where basically you would have a clinician have to make the order referral to get this testing done. Now with this program, you've got an algorithm that you can now somewhat automate the process by which patients are identified for eligibility for this test.
Yeah, I think it's more accurate to say is these patients weren't getting referred, right? They were just bouncing around. We're really looking for the patients that aren't coming to genetics. We have an excellent genetics program here at our center, and most patients do get referred, but it's really the ones that are getting missed because they have a rare disease. The presentation is multi-system, and once again, as Alex mentioned, if you're not a genetic specialist, you might not be thinking about that as a genetics presentation. So we're finding the patients that are slipping through the cracks. And, you saw that in the retrospective phase, we were finding these teenagers, but the average age of the patient that we're flagging now is closer to 1 to 2 years of age.
How did you build the algorithm?
We started in the pre-chat GPT days, right? And we were trying a whole host of different techniques, but what we actually found was because of the data set is so unbalanced, the most effective algorithm was actually kind of your 1980s expert system. So expert clinician curated criteria applied to our data. We iterated on 6 different versions in order to find that final version that is once again flagging the right patients, but not flagging so many patients that it would overwhelm the system. We did a very large chart review, and we found that we aren't missing any appropriate selections either. So that was important for us to make sure that the algorithm is tuned in that way.
Yeah, when we were developing the criteria, our goal was to be as inclusive as possible. We wanted to identify any and all types of rare disease. We didn't want to just identify, for example, those that have treatments already or those that fit a small category. We really started off with, at that time, our Ministry of Health criteria for exome sequencing, which was the broadest test available back in 2020, 2021. And that was really the basis for our criteria, kind of that multi-system presentation, patients who had not been referred to us yet that would really benefit from this broad test. And that's where we saw a lot of success for those who are being referred. They were not just those that were suspected to have a rare disease diagnosis. They were coming, they were getting a diagnosis, they were walking away with more precision, medical management after that.
So what's next? What are you looking to do next with this product?
So we're really looking to kind of scale this across Canada and really globally. We really see this as a benefit to the rare disease community. As Alex mentioned, there are other companies that do this type of work. There is a very clear medication or therapeutic at the end of this that costs a lot of money because it's a rare disease. And so typically those patients are the ones that have algorithms designed specifically to find them. And those are the ones that are being targeted by these algorithms. But for us, it's really more of a health equity kind of solution. We're trying to make sure that all of these patients are given that opportunity and given their diagnosis. Just because, there might not be a pharmaceutical, it doesn't mean that there's nothing that we can do for this patient. So we can For instance, one of the patients we flagged was struggling in school. They didn't have the academic resources available to them because they didn't have that label in the educational system. And so getting their diagnosis immediately allowed them to get into, to have additional educational resources at school, and that he's doing better academically as a result of that. So that's still a win for the family. And of course, the peace of mind that comes with knowing what the ultimate diagnosis is. Another patient of ours was being followed by neurosurgery a lot more closely. Then afterwards, we gave him the diagnosis. And actually, you know what? I think this one Alex can explain better because it's a little bit more clinical. Alex, you want to take this one?
Yeah. So one of the things that we've been trying to show at the UCL, or not just here, but as we expand nationally, is it is something, of course, that will primarily benefit the rare disease community, but it can also benefit a public health care system. So when we identify these patients, they have a clear diagnosis, and for one of the patients that we've diagnosed, we're actually able to limit the amount of follow up with neurosurgery based on one of their health issues being identified as benign as part of their condition. So you're actually able to minimize their healthcare utilization and save, our province here in Ontario, that amount of neurosurgery follow-up because that patient actually truly didn't need it. So as we scale this, nationally and internationally as well, we really see it as something that's, benefiting the rare disease community. It's benefiting public healthcare systems, but, also privatized healthcare systems as well. It's driving medical treatment and pharmaceutical treatment. It's bringing health equity, and it's also really driving research. So Ivan had mentioned that, we're a big catalyst for rare disease research here, at CHEO. And, we've built this pipeline of using Thinker to identify these patients, making sure they're getting into have their clinical testing, but then we're also trying to focus on, that post-diagnosis journey as well. So making sure that they have access to resources specific to their condition, treatments and clinical trials specific to their condition. So as we scale this, around our province, around Canada, we've been working very closely with McMaster Children's Hospital in Hamilton and the Alberta Health Services in, a couple of provinces over from us. We're really focusing on that entire rare disease continuum to ensure that, these patients aren't just being identified, but they're getting the right course of care up until their diagnosis and then after they receive their diagnosis as well.
Thanks, Alex. That's great. The work you all are doing is amazing. So not only are you helping families get, answers to questions they need, these kids are getting better outcomes both clinically but also educationally and perhaps socially as they're able to know what their diagnosis is and get treatment as needed. But you're also perhaps, with this last example, able to create more efficiency and cost effectiveness for the delivery of healthcare across provinces in Canada because of the intelligence you're providing to the care system around what's needed and what's not based on test results and diagnostics.
A good example is one of the patients was diagnosed with a condition where there's a very high risk of renal cancer. And so the screening needs to start right away because they have a 30% lifetime risk of actually developing renal cancer. So that's another example of now that we know what this patient has, we're much more likely to catch it early if that patient does develop renal cancer, which is another, not only an outcomes thing, but also a savings to the health system as well.
It's amazing. I mean, the reality is we don't have enough of these types of algorithms in pediatrics, and I think you all are on the cutting edge of building and deploying them and seeing the value and outcomes, whether it's clinical or financial.
It's been a very interesting journey because we are, originating in research. And so we've had to kind of go through all of these different iterations of how do we drag this thing from a very conceptual research project into now a clinical deployment within CHEO and now scaling this out to other centers.
Yeah.
Trying to figure out some of these commercialization pathways, how do we engage with government to try to do this? And even just navigating the regulatory space, which is very much evolving with AI and being at the forefront of technology, and also just now trying to navigate these regulatory pathways that are almost shifting as we speak. And with the advent of some of the frontier models and other techniques within the AI space, we're actually kind of layering them on top of our existing algorithm to try to improve the functionality and improve our algorithm as a whole, and the user experience of the folks using it as well. We're now taking some of the kind of the large language model approaches and using that to sift through some of the unstructured data as well.
Thank you for coming on the show and talking about it, and appreciate all the kind of cutting edge work you're doing on this space. Thank you. All right. Thank you for joining us for your dose of optimism.
Make sure to check out our show notes to get more information about our guests and the work they're doing. Visit our podcast page on the KidsX website to join our podcast community and to learn more about pediatric innovation. Thank you to our sponsors and to our presenting partner, KidsX. Please subscribe wherever you get your podcasts, and remember, it takes a village to make sure our kids grow into healthy adults. So volunteer at your local library, help out at the community center, and if you're so inspired, donate to your local children's hospital. All right, see you next time. The content, views, opinions, and information presented on this podcast do not reflect the views of Children's Hospital Los Angeles or of the sponsors of the podcast.